Memorizing endless lists of gastrointestinal symptoms creates a severe vulnerability for medical students. Relying on broad clinical presentations is inefficient because diseases across the GI tract routinely present with the exact same surface-level features. This diagnostic scorecard illustrates the problem. If a patient presents with chronic diarrhea, severe malabsorption, and vague right upper quadrant pain, the clinical picture matches both Crohn's disease and Whipple disease perfectly. Attempting to make a diagnosis based on these overlapping complaints during board exams or ward rotations guarantees diagnostic errors. The symptoms alone do not provide enough resolution to select the correct therapy. The necessary correction is to abandon rote symptom memorization. Diagnostic accuracy requires mapping the precise cellular mechanisms and histological differences driving the illness. Building comparative mental models at the tissue level provides the only durable strategy to instantly identify the definitive differentiating factor hidden inside a complex clinical vignette. Consider a middle-aged patient presenting with chronic diarrhea, a steady loss of weight, and profound malabsorption. This side-by-side matrix strips away the shared gross symptoms and compares the underlying histology of Crohn's disease and Whipple disease. In Crohn's disease, the inflammation is deep and aggressive. Biopsies reveal patchy, transmural inflammation featuring non-caseating granulomas that penetrate the entire thickness of the bowel wall. Whipple disease is far more superficial. The defining feature here is the presence of foamy macrophages confined strictly to the lamina propria. The triggers driving these cellular changes are entirely different. Crohn is driven by an autoimmune TNF-alpha-mediated macrophage response. Whipple disease is caused by an active infection of a gram-positive bacterium, Tropharema whipplei, which stains positive with periodic acid Schiff. Identifying these divergent microscopic triggers is critical because they dictate completely opposite treatment regimens. Crohn disease requires heavy immunosuppression, typically with anti-TNF-alpha agents like infliximab. Whipple disease requires a targeted course of antibiotics to eradicate the bacilli. Furthermore, the depth of the disease dictates the downstream risks. The transmural nature of Crohn disease routinely causes physical complications like fibrotic strictures and penetrating fistulas, structural damage that does not occur in the superficial inflammation of Whipple disease. Because the clinical presentations overlap so heavily, securing a diagnosis and prescribing the correct intervention relies strictly on interpreting the biopsy data. Moving to the right upper quadrant, diagnosing the root cause of acute cholecystitis requires tracking the mechanism of inflammation. This decision tree splits gallbladder inflammation into two distinct causal pathways, a direct mechanical blockage or a broad systemic illness. The mechanical pathway is calculus cholecystitis. Gallstones physically obstruct the cystic duct. When the duodenum releases cholecystechidin after a fat-rich meal, the gallbladder contracts, forcing the stone against the outlet and causing localized ischemia and biliary colic. The systemic pathway is acalculous cholecystitis. This occurs without stones, exclusively in critically ill patients dealing with severe burns, sepsis, or trauma. The sheer physical stress causes gallbladder stasis, which eventually leads to ischemic inflammation. These contrasting mechanisms require different diagnostic imaging strategies. A rapid bedside ultrasound easily identifies physical stones and wall thickening in calculus cases. But when the ultrasound is inconclusive, often the case in acalculus patients, a nuclear HIDA scan is necessary to functionally assess the patency of the cystic duct. Factoring in the patient's environmental context, an ambulatory patient versus someone in the ICU rapidly predicts the etiology. Clinicians must be vigilant, as the signs of acalculous cholecystitis are dangerously subtle in sedated patients. In gastrointestinal pathologies, isolating an obscure upstream trigger is the only way to predict massive downstream complications. This flow sequence tracks Helicobacter pylori infection in the stomach. The bacteria specifically target and destroy the somatostatin-secreting cells located in the gastric antrum, which removes the brakes on gastrin production. The resulting unchecked gastrin spike drives a severe increase in gastric acid. This acid load empties into the small intestine, directly causing duodenal peptic ulcers, which require quadruple therapy to fully eradicate. Upstream triggers also emerge from a patient's geography, specifically when considering the specific housing conditions found in rural Latin America. Chagas disease is an endemic protozoal illness. The primary vector readily infests the cracked adobe walls of homes in these rural areas. The dense organic material of thatched roofs also provides a perfect primary habitat for the vector, exposing the residents below to acute infection. This is the triatom bug, the specific parasitic vector responsible for transmitting the illness. While the initial infection is often asymptomatic, the delayed consequence is severe. Decades after exposure, patients develop chronic Chagas cardiomyopathy, uniquely characterized by localized apical wall thinning and large aneurysm development. Finally, we see upstream triggers heavily influence hepatobiliary vascular networks. This vascular nap tracks drainage from the stomach. Pancreatic inflammation or ductal adenocarcinoma can cause a localized blood clot strictly within the splenic vein. Because the short gastric veins normally drain into the splenic vein, this clot forces pressurized blood to back up. This creates isolated gastric varices exclusively in the fundus, completely independent of systemic portal hypertension. Whether dealing with a regional parasite, a bacterial infection, or a localized venous clot, diagnostic attention must remain focused on the precise upstream trigger, rather than just the localized bleeding or organ failure. Achieving reliable accuracy in GI and hepatobiliary diagnostics requires mapping the precise histological or mechanical differentiator. Counting generic symptoms is a dead end. This quadrant chart maps the clinical return on investment. Rote memorization of symptoms requires low effort, but yields low clinical impact. Mapping cellular and mechanical pathways requires high upfront effort, but directly drives high-impact clinical accuracy. This method is highly efficient for board preparation and essential for diagnosticians who need to rapidly cut through distracting clinical vignettes like chronic diarrhea or vague abdominal pain. This level of mechanistic depth is certainly over clinical practice and definitive diagnosis. It is mandatory. Understanding the mechanical or cellular why behind a varus, a stricture, or an ulcer provides the only reliable anchor for selecting the correct, life-saving intervention.